The broadcast is now starting. All attendees are in listen-only mode.
Hello everyone, and welcome to tonight's Interprofessional Virtual Grand Rounds. Before I introduce myself, I'm going to bring your attention to the poll that should be on your screen now. The poll asks, in which profession or role do you represent? So as I introduce myself, just feel free to select the answer that best applies to you. My name is Michael Tarr, and I'm a fourth-year medical student at New York Medical College, and I'm the AADMD Virtual Grand Round Task Force Director. The Grand Round Task Force is a new group of 7 medical and dental students and residents from around the country who are passionate about improving education of medical and dental professionals on how to treat individuals with IDD. So let's review that poll. We have joining us tonight 26% of our participants are working in administration, 5% are students, 16% are coming from medicine, and 53% said they're coming from other fields. So I'm going to pop up the next poll, and once again, please answer in the way that best answer with the answer that best applies to you. So the AADMD Virtual Grand Round sessions seek to create a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the Grand Round sessions is to expand and strengthen the IDD healthcare workforce across a spectrum of experience levels. At the end of the presentation, please stay on with us to ask any questions you have for the presenters. Questions can be submitted through the Questions tab on your gray control panel on your screen. And in addition, you can download tonight's presentation from the Handouts tab for future reference. And that Handouts tab is also on your gray control panel. So I'm going to close this poll and share that with you all. It asks, what stage of your career are you in? We have 5% are in pre-health profession training, 5% are health profession training, 84% are currently practicing, and 5% are retired from practice. So most of you are in the workforce. I'm going to put up the last poll. Once again, please answer in the way that best matches. So this one asks, what do you hope to gain from this webinar? So you can answer however you'd like. So tomorrow after the webinar, you'll receive a link to a post-webinar survey. If you could please just take a minute to give us your input, it'd be very helpful for improving future webinars. And the average person spends about 3 minutes taking the survey, so it shouldn't take any time at all. And tonight's Virtual Grand Rounds is being presented by the Saskatoon Sexual Health and the Saskatchewan Association for Community Living. So before I introduce our presenters, let's close the last poll and see why you are all joining us. So it asks, what do you hope to gain from this webinar? 5% of you said you're looking to learn foundational healthcare concepts for individuals with IDD. 9% said networking. 55% said gain interprofessional perspectives on healthcare for individuals with IDD. 27% said gain pearls from complex and challenging clinical cases. And 5% said CE credits. All right. So our presenters tonight, we have Amy Plowman, who joined the Saskatchewan Association for Community Living on June 2nd, 2015, to facilitate the self-directed funding demonstration project, which is now an option across the province. She graduated from the University of Saskatchewan in 2005 with her sociology degree and completed her social work degree in 2014 from the University of Regina. We also have Dallas joining us, and Dallas is a community inclusion consultant from the Saskatchewan Association for Community Living, and he's worked within the disability support sector for about 10 years. And finally, we have Natalia Mason, who is a registered social worker and the Education and Outreach Coordinator at Saskatoon Sexual Health in Saskatoon, Saskatchewan, Canada. Say that 5 times fast. She holds a Bachelor of the Arts in Psychology and a Bachelor's of Social Work. She's currently completing a Master's in Women's Gender and Sexuality Studies at the University of Saskatchewan and a postgraduate certificate in Sexual Health at the University of Alberta. I hope you all enjoyed tonight's presentation, and with that, I will give the floor to our presenters.
Hello, everybody. Thanks for joining us tonight. This is Dallas Tenerenko, and I work with the Saskatchewan Association for Community Living, and I'm here with Amy Leonard.
Hi, good evening.
And Natalia Mason from Saskatoon Sexual Health.
Hey, how's it going tonight?
We thought we'd probably start off the evening with just kind of giving you a brief overview of what each of our organizations do in the community, and then we'll get kind of into how our initiative kind of came to be and kind of discuss that from there. So, so the Saskatchewan Association for Community Living has existed for, we just celebrated our 61st year. So we have been around for a while. We are a provincial advocacy organization within Saskatchewan that supports individuals and their families experiencing intellectual disabilities. Our vision is that all individuals are valued, supported, and included in all aspects of life. And our mission is to ensure that citizens of Saskatchewan who have intellectual disabilities are valued, supported, and included members of society and have opportunities and choices in all aspects of life. Our typical work is kind of rooted within grassroots advocacy supports. That is kind of realized in two streams of support. So one is individual one-to-one advocacy supports for individuals in the community, and the other is more intensive, broader-based systemic change. So much of our one-to-one supports inform our systemic processes, and ideally we split our time between both, but that is not necessarily the case. So moving on here.
So Saskatoon Sexual Health is a nonprofit organization. I've been lucky enough to work at Saskatoon Sexual Health coming up on 3 years now. This is our fancy new vision and mission here, but our vision is a society where sexual and reproductive health and rights are celebrated and accessible to all. We provide sexual and reproductive health services in Saskatoon and area with an emphasis on safe, inclusive, and empowering clinical care and education. We work with diverse communities to promote healthy and informed sexualities. So we kind of have two main program components, I guess, if you will. For clinical services, we do have a regular functioning sexual health clinic. So we employ a number of doctors as well as a full-time nurse. And sometimes we have pharmacists coming through our clinic. We also have a medical office assistant, a phlebotomist. And so they do regular testing, STI testing, pap smears, IUD insertions, that kind of thing. And then I run the education program, so I am out in community groups and schools presenting on sexual health and everything that relates to that.
So I'll just give a little bit of information in terms of the project history and how this all kind of began. So within Saskatchewan Association for Community Living, we received a phone call from a Prairie West School Division superintendent. They were having some trouble within their school division in terms of staff members, teachers, not entirely sure how to support the students with disabilities who were having some sexual behaviors. So they had asked us to provide some potential education to the students in terms of identifying gaps where they weren't able to provide some of that sexual education, as well as to the teachers and the service providers within the school system, so that they could have a better understanding of how to approach it. So that's how it started in 2016.
And in terms of our involvement, so like I mentioned, Saskatoon Sexual Health provides sexual health education in the community. And a large portion of requests for presentations and stuff come from classrooms or organizations that are dealing with marginalized or oppressed groups of people. And so as an educator, I've been getting lots of requests to work with groups that support individuals with intellectual or cognitive disabilities. So we decided to pursue some funding to offer a program that targeted that population specifically. So in January of 2017, we started shopping around to different community agencies who support those communities, looking for a partner to work with on this project. It was really important for us that we found someone who's already involved with the community. That's not our specialty as an organization, and so we wanted to make sure that the program was really strong. We thought that that was going to be the best way to do that. So we ended up meeting Amy and Dallas from SACL. I'm just going to call them by their acronym. And that's when we started working on this project together.
And something that was kind of unique to the supports that we provide here at the SACL is we support quite a few individuals that are adults that are not part of any particular education system. So we have found that part of that trend or gap analysis in support services in the community regarding sexual health were not accessible to the adults that we supported once they were out of that more formalized system of engagement. So we had reached out to Creative Options Regina. They are a community-based organization based out of Regina, Saskatchewan that provides day program and residential supports to individuals with intellectual disabilities. They're very unique in the way that they provide their supports. They utilize a person-centered and holistic approach, identifying the needs, wants, and desires of the individuals that they support and empower them to make healthy choices in their lives. But beyond that, they are not there to make the choices for them. So we had reached out to Creative Options Regina and asked, had they engaged individuals that they support in a meaningful capacity along the lines of sexual wellness and health. And they conveniently were also working on an initiative at the exact same time that we were pulling together our supports and entering into a partnership. So Creative Options Regina was very eager to partner with us to provide us all of the materials and resources that they had developed or that they had begged, borrowed, or stole from other places. And so it was just really opportune timing. And from there, we took the existing materials and engaged in a pilot project with a rural school in Saskatchewan in the municipality, or I guess it's a town now, of Bigger. And this was one of the schools that we had previous contact with regarding some of the students that were struggling with sexual education and their sexuality, and there was some challenging behaviors around that. The school had supported the student very well. There was a few other schools in the division with some similar incidents that did not support the students well through the process. So it was identified by the superintendent of the region that Bigger School would be a good place to kind of start to see if the quality and the delivery of our materials was appropriate for the individuals. So we completed the pilot during June of 2017. It was a tremendous success, and we learned a lot by it. It was a very diverse group of students that learned with us. They were from a variety of different grades, and it was definitely a challenge to make sure that everybody was getting something out of the program, which is something we'll talk about a little bit later.
And then following that, in August, we did some program evaluation. We actually had to do a little bit of regrouping in terms of funding for this project. And if we have time towards the end, I'll speak to that a little bit, because funding is obviously a huge challenge, especially for nonprofits who are trying to provide programming. And then I'll also speak to the stakeholders meeting once we get to the end here.
So I think this slide will speak to the fact that individuals with intellectual disabilities often face many challenges in terms of accessing sexual health education. So some common myths are that individuals with disabilities don't have any sexual desires, which is obviously not the case. They are also seen as individuals that need support and can't make decisions for themselves. And within SACL here, I mean, we work with a number of people who are able to make many decisions for themselves and don't always need somebody else to make that, especially in terms of sexuality. Another myth is that they're unable to consent to sexual activity, and that if they are provided with that sexual health education, then that will create a motivator for them to become more sexually promiscuous or aggressive if they have that information. Some barriers in terms of accessing the sexual health education is that oftentimes I think families are trying to protect their sons or daughters who are adult and have sexual desires. They want to protect them so that they're not harmed or put in situations where they could be at risk. So parents are often keeping them in a bubble and trying to exclude them from some of that sexual health education, which also in turn causes exclusion within the education system as well. So unfortunately, there are some gaps there in terms of accessibility.
So I kind of breezed past the original slide, but we titled our presentation tonight "Already Doing It," which I think is appropriate for identifying with whom we typically work. The individuals that we support that experience intellectual disabilities are just like every one of us. They are engaged in the same activities. They have the same desires, wants, and needs regarding their sexuality. They're dating, they're having children, they're getting married, they're moving in together, they have the same dreams, aspirations, and goals as everyone else. But there's a caveat to that. Typically they lack the resources or the knowledge base to make healthy decisions with regards to their sexuality and sexual activity, which can obviously lead to an increase of risk-taking behaviors, whether that be being with individuals that are posing a physical risk to them, not using contraceptives, unplanned pregnancies, sexually transmitted infections. The prevalence of those things occurring are quite high with the individuals that we support. They also may find social interactions challenging, and they don't necessarily know how to develop those healthy relationships because they've never actually been provided the opportunity. And this is kind of building off of what Amy just said. We encounter a lot of individuals that have family members in their lives or individuals in their lives, whether they be teachers, medical professionals, or otherwise, that very much adopt this protectionist attitude that individuals that experience intellectual disabilities need to be protected all the time, when the reality is all of us make very poor decisions and potentially compromise our health and well-being in a multitude of ways, but the best we can do is empower individuals to make better choices in their lives, but not to insulate them from making mistakes that they can very much learn from and come back more informed and better educated to make better choices. So I'll just talk a little bit about kind of some more particulars about that. So typically women with intellectual disabilities experience sexual violence in various forms, which could be a violation of privacy, restraint, strip searches, confinement, that replicate the trauma of rape by staff and other inmates, residents of institutions, forced abortion, forced sterilization. Within Canada, and I know this is very much true in other parts of the world, including the United States, institutional living is still very much prevalent, depending on where you go. That institutionalization and that philosophy of at one time the best practice, and that's how we supported individuals with intellectual disabilities, carries forward into many of the practices that we as professionals offer or provide those with intellectual disabilities, which is obviously very detrimental to overall health, but specifically within our conversation, sexual health. So in a study comparing the rates of instances of sexual and physical assault among women with and women without disabilities, it was determined that women with disabilities were 4 times more likely to have experienced sexual assault than women without disabilities. This is something that is substantiated in our work at the SACL and with, I'm sure, Natalia at the Saskatoon Sexual Health as well. Women with disabilities who are from Indigenous or rural communities may lack information about access to available services for prevention and response to violence and abuse. We encounter that in the major centers as well. It is a significant struggle, and we haven't been able to really figure out a best way provide that education until now, and provide it as an inclusive option for individuals that we support.
So, question 1, which of the following are misconceptions about people with intellectual disabilities? So A, they lack capacity to consent to sexual activity. B, they are asexual and do not have sexual desires. C, they have access to timely and accurate sexual health resources. Or D, they require protection through institutional living and care. So with that being said, all of these are misconceptions.
Okay, so talking about comprehensive sexuality education, which is something that is really important to me and honestly something that gets me a little too jazzed up. But comprehensive sexuality education is actually the UNESCO gold standard in terms of sexuality education, which means that young people are offered a full spectrum of information about sexuality so that they are able to make healthy and informed choices. It's also really important to remember that sexual health is a human right. Sometimes we treat sexual health and sexuality as a luxury or as an add-on, but as humans, that's something that we deserve access to. So sexual health incorporates our physical, emotional, mental, and social well-being. So it's a multitude of different factors interacting together. And it's also really important to note that sexual health as a human right means that we all deserve a pleasurable and safe sex life, which is something that doesn't necessarily get focused on when we're teaching sexuality education. And lots of times the things that prevent people from having access to comprehensive sexuality education is the idea that providing young people with information about sex is going to lead them to have sex earlier and more often. But many studies have found that teaching comprehensive sexuality education doesn't make them more likely to have sex earlier. It actually prolongs that sexual debut, and they're more likely to make informed choices when they do choose to have sex. And it's also really important to note that in contrast to things like abstinence-only education programs, young people who take comprehensive sexuality education programs are less likely to experience adverse side effects like unintentional pregnancies and sexually transmitted infections.
So there's a tremendous amount of research dedicated to the positive impact that sexual health education for any individual has, but specifically for individuals with intellectual disabilities. That would obviously lead to making, like Natalia said, more or better informed decisions about how to have a healthy relationship. It empowers individuals to make their own decisions related to their sexual health, and obviously it reduces the risk of them being the victims of sexual abuse, and it reduces inappropriate sexual expression. Often we work with individuals that are very much labeled, and the way they express themselves is kind of framed in this context of challenging behaviors, and probably none more so than around sexual expression. When professionals realize the context in which these individuals are coming to us trying to access this information or these advocacy supports, oftentimes we forget that many of those that we support are living in group environments with 4 or more individuals, and they very much lack the privacy to make some of these choices, even though they're making good choices and they're being appropriate. They just don't actually have a physical space that they can identify as their own to engage in sexual activity. So there was, to give you a kind of a quick story about that, there was an individual, a young woman that I was supporting in her 30s, who had expressed herself in a variety of ways over the years, and was a very she was very engaged with her partners, and she was over at his home the one day, and he was living in a group environment, and they decided to become sexual just sitting on the couch in front of everybody. And when it was identified that behavior wasn't appropriate, they didn't understand why, because they didn't have another spot or a place or an area where they could have that contact and have that privacy. And on the couch in the living room was really the only option for them outside of going outside into a park. So when we kind of reframe that context and why some of the individuals are making the decisions that they do, we can better understand how to best provide them the education, the resources to express themselves in a way that is empowering and can create a safer environment.
So this is just a little color here. Like I said, I get to work in community groups, and so these are some questions that I was asked in a group that supports people with intellectual disabilities. And I just want to kind of highlight the fact that these questions are very similar to questions that I would get in any other classroom, and they're also fun and probably something that you guys can identify with from when you were younger. So, what is sex? Huge question. Not sure I totally have an answer for that. Do you have to be nice or mean? So maybe, you know, trying to understand what flirting is. Am I supposed to be nice to this person, or am I supposed to be mean to them? Why do we have sex? Does everyone have to do sex? What is an STI? Do people get pregnant from doing it? And why do people do it? And I'm sure that's a question on everyone's mind still. And lots of these questions are coming up because of the kind of social circumstances that we're living in right now. So I often tell people, especially like healthcare providers, educators, that it's really important to remember that normal changes and that we are kind of dealing with a new normal now. So things that young people are being exposed to are pornography. Pornography is pretty much ubiquitous. It is very likely that by the time a young person is like 11, 12, they've already been exposed to some form of pornography. So knowing that that's out there and that they're likely going to see it is a kind of unique challenge. Also, just the general hypersexualization in the media. So we know that we've been taught that sex sells and it's everywhere, but we don't necessarily get the education or the literacy skills that are necessary to unpack those sort of messages. Sexting is another big thing that has been coming up a lot in schools. And I know that I've been going into classrooms to deal with kids as young as 12 sexting, and that's not something that's exclusive to typical young people. Lots of young people are engaging in that sort of behavior, and we're not going to put a stop to it. So we just want to make sure that we're providing people with skills and tools so that they can navigate that safely. Also, online dating. And that's huge for lots of different populations who are marginalized or maybe who don't have access to similar peers. And so that's definitely something that's true for people with intellectual disabilities as well. I know that there has been there's an online dating website that's for people with a variety of forms of disabilities, which sounds like a really awesome opportunity for them to connect, but it also presents challenges in that if you're talking about a population of people who might be a little bit more at risk or a little bit more vulnerable, then you want to make sure that they're also not being taken advantage of in that kind of a setting. And then also just dealing with social media as a whole. That's kind of something that's tricky for everyone to navigate. I'm in my 20s and I still haven't figured it out. So you can imagine that if you've got some other barriers to understanding how social media and like the permanence of social media, stuff like that works, you're going to need a little bit more support. And so all of those factors become a little bit more complex for adolescents who are living with intellectual disabilities. And then I just wanted to point this out because from where I'm working from, Saskatchewan isn't doing very well in terms of sexual health education. So because we're primarily serving people who are living in Saskatchewan, it's also important to note that nationally we have the highest rate of infection for HIV. We've also got the highest rate of infection for chlamydia, and we also have the highest rate of unintended teen pregnancy. So that means across the board, we're not doing very well in classrooms. And so it becomes even more likely that populations that are a little bit more challenging to deal with get pushed to the side. Okay, question 2. So comprehensive sexual health education is correlated with an increased risk of incidence of sexual activity and unintended pregnancy in teenage populations. Is that true or false? And that one is false.
So we had some project goals, and one was obviously to help learners develop effective communication skills, and to empower them to make decisions and to build meaningful relationships within their lives. We wanted to provide information to learners about the importance of good personal hygiene. This was probably an area that I maybe overlooked prior to this. I didn't think it was going to be of that great of importance. I just assumed it was something that many of us have already learned, but there was quite a bit of work and discussion around that. One of our goals too was to help learners understand and recognize healthy versus unhealthy relationships. That was definitely a challenge as well that we'll speak a little bit more to later. And we wanted to provide learners the opportunity to understand boundaries for touch and talk in different types of relationships. And like that social cueing. And we also wanted to ensure learners were receiving accurate, comprehensive sexual health education to be able to make informed decisions. We know that in the moment, you may not make the best choices, so we wanted to make sure that learners definitely had access to that information and as often as they needed to feel comfortable navigating those very complex social situations.
And so these are just some of our project values, so things that were really important to us as we were kind of adapting our program and trying to figure out where we wanted to take it. So first and foremost, sex positive. Saskatoon Sexual Health is an organization that's sex positive. And that means that we treat sexual health as a human right, like I mentioned, but it also means that we talk about it as being something that's good in people's lives and that we avoid that risk and consequence narrative. Because lots of times when you're talking to young people about sexual health, all they hear is that they're going to get chlamydia, get pregnant, and die. And we know that that's not the case. So we want to make sure that we focus on the positives as well, because that has better outcomes. It was also really important that this project is inclusive, so that we're accounting for diverse sexualities and gender identities, along with the fact that people often assume that people with intellectual disabilities are asexual. They also take that to mean that if they were to be sexual, they're going to be heterosexual, and that's definitely not the case. People with intellectual disabilities can be on all parts of the gender and sexuality spectrum, so it's important to make sure that we're talking about those diverse experiences as well. Also really important that the project was intersectional, so making sure that we account for the interaction of those diverse identities, so that some people are female and that's going to affect their experience. Some people are going to identify as gay or transgender, and we need to be remembering that when we're developing the curriculum and the tools. Also important that it was interactive, and this was something as we learned more when we went through the program, but no one likes to sit in a classroom and just listen to a lecture. So it was really important that we accounted for a variety of different learning styles by incorporating, like role play or hands-on activities and stuff like that. We also want it to be informative, so we want to make sure that we're staying current, that the information that we're presenting to these people is relevant and that it's going to be something that is useful in their lives. And then we're also following through with the nothing about us without us philosophical principle. So like we mentioned, I'm a social worker, and that's huge for social workers, and that means that you involve the populations that you're working with when you're trying to develop programs that are going to be serving them, because if you don't do that, then you just end up having gross oversights and you have to go back and redo work.
So the actual program started we did our pilot project over in Bigger, just about an hour away from Saskatoon, and we had 8 individuals that were identified to participate in the program. We had males and females, and there was a variety of ages across the board, so there was a good mix there. So there were 10 modules, and we intended to deliver that over 10 weeks. So what we had discovered as we were moving through the modules is that not everybody was going to learn, obviously, at the same pace. So one of the key pieces that we took from that is that in future delivery of the program, we'll definitely take the time ahead of time to do some assessments in terms of capacity to understand some of the different pieces of the program. So when we first started the program, I'm going to actually let Dallas speak to the very first day.
So we arrived for the first day. We weren't really getting into any of the modules yet. We were just doing kind of a meet and greet and getting to know the participants of the program. And the first question that we asked was, does everybody know why they're here? And we know that, like, obviously sexual health and sexuality can be kind of built up as very much a taboo topic with young individuals. So it was very quiet for a while, and one young fellow in the group very enthusiastically punched into the air and said, "Sexual intercourse." And he just kind of paused there for a good minute or so, not moving. And immediately I was like, oh yeah, like, this guy gets it. We're starting off on a pretty good note. And honestly, it really set the tone. I don't think we could have devised a better icebreaker than him just identifying why he was there and how pumped up he was to learn.
For sure. And what I found from as we went through the 10 weeks of delivering this program is that eagerness was at the forefront of each class. So every time we came out there, everybody, you know, if they could make it and were healthy and had an opportunity to attend, they definitely were, and they were eager to learn. And I think that just really speaks to the fact that that education piece for them was really important, and they really wanted it, and they had a lot of really good questions. So I'm just going to touch on a couple of the different modules that we delivered that kind of stand out for me when we were delivering them. So module 3 was the health and wellness personal hygiene one, and during that particular class, it was a really concerted effort with the school as well as with us. So we made sure that we put together little hygiene packs within the community. They were able to access a bunch of different resources, and then when we delivered that actual program, we went through each thing. So for example, there was a toothbrush, dental floss, shampoo, conditioner, deodorant, tampons, pads, and during this particular class, it was really apparent that some of the individuals in the class really didn't like the idea of talking about periods, that sort of thing, or the opposite sex sort of stuff. However, everybody sat in the room and we continued to talk about it, and I felt like it was a really empowering piece, because at some point these individuals could be potential partners to somebody. So that one really stands out for me. Another one that really stands out for me was personal health. So there was the boundary one, so building self-confidence and personal safety. So it was really teaching people that they're allowed to have that personal space in their life, and they can make those decisions for themselves in terms of whether or not somebody can enter it, and allowing them to have that confidence to say, no, we don't need to, no, you're not allowed in my personal boundary zone. So what we found as well during delivering that program is that the activity that we chose to do was very interactive during that class, and it was something that throughout each module always came and they talked about. So I think when delivering this program, I think, as Dallas had mentioned, it's really important that we're not just doing that classroom lecture style, because when we're delivering this type of program, if we can have visual aids or interactive activities, I feel like that is a much deeper way of learning for a lot of these individuals in this class. So that was some of the things that we learned. And another thing that ended up happening during this program with the 8 individuals that were in it is that the understanding was very different amongst the group. So the individual who was super excited in the beginning to learn about sexual health was very eager and had a really good understanding of sexuality and really wanted some deeper information. So there were 4 individuals that really seemed to understand a lot of the different modules and different things about sexual health and wanted more deeper information. And then the other 4 were kind of really moving at a slower pace. So we ended up dividing the group up, and we had one person deliver it to the individuals, and they made it through all 10 modules. And then the other group ended up going back and redoing some of the modules, but made it all the way till module 8. So the delivery of the program was pretty fun. It was pretty exciting. And I felt like even though we had to split the group up and not everybody did make it through all 10, there was still pieces of the program that they were able to walk away with. So it felt like it was definitely worth our time, and definitely gathered a lot of learnings from that experience.
So we identified a few outcomes that we achieved with this particular group of participants, and one was they definitely identified that they knew how to access existing community resources where they didn't otherwise know how they would be able to express what they need and then get that in a timely manner, and especially within a rural community here in the province. That's definitely another challenge in itself. There was definitely a noted increase in open communication with supportive team members. So we did have a couple teachers and education assistants participate in the program with us as we were delivering it to the students. And it was a very interesting interaction between all of those team members and the participants when we were delivering the information to them and engaging in some of more of the group work and that role-playing piece. And the dialogue around sexuality was as the modules progressed, because we did one module for every week, and each module was about an hour and a half. So that was 10 weeks of programming. There was definitely an increased comfort amongst the participants to kind of come up with whatever that they were thinking of that maybe wasn't at the forefront of their thought process at the beginning of the program. And that kind of comes to the next point, is the distinguishing between fictional and authentic sexual relationships. As the programming progressed, there was a lot of talk of what a man or woman should do in a relationship, or how a gay couple would interact with one another, and what those sexual acts between those individuals may look like. It was very much rooted within pornography, is probably where majority of their questions and their experience had come from, and identifying that those were fictionalized relationships. Although the sex was real as a physical act, it was not as it was presented, and that was very difficult and challenging for us to broach with the participants, because many of them identified that as very much a reality, and they could distinguish that watching a pornographic film was very different than watching a film like at the local Cineplex, and they couldn't distinguish necessarily between why the two would both be considered fake or fabricated or not real.
Okay, so after having successfully done our first kind of pilot program, we obviously started looking towards future directions. And the first thing that was a huge hurdle to overcome was securing stable funding. So like I mentioned, getting funding for nonprofits is really challenging. You're applying to lots of different agencies for grants. And unfortunately, the granting agency we had initially applied to continue this project declined our funding submission. So we had to come up with a secondary plan. And so that's kind of where we are at right now. We've got a grant that's going to be going in at the end of the month. But we also thought it was really important to partner with the local school divisions, with the Ministry of Social Services, the Ministry of Justice, and other community-based organizations, because you're stronger when you're working with those organizations. And we're also wanting to make sure that we're not duplicating services that are being offered elsewhere. We want to be as effective as possible. And in pursuing those partnerships, we met a wonderful woman named Dr. Lee Murray, and she works at the College of Nursing at the University of Saskatchewan, and she has been pursuing not only some research in this area, but also a program that's been offered in some of the schools locally. So going forward, we're now working with her, and that's really fantastic. We also want to work on a train the trainer program. So while it's really great that me, Dallas, and Amy are good at our jobs, and it would be awesome if we could hit every community in Saskatchewan, that's just not realistic, and financially that's not feasible. So what would be ideal is if we could offer workshops, say in northern Saskatchewan and southern Saskatchewan, so that we can have healthcare professionals and educators who are trained to provide this programming so that they can do it locally. And that's better for the participants in the program as well, because they're familiar faces, and so they might be a little bit more comfortable with that. We're also going to work on developing some teaching tools and resources. The Tell It Like It Is program was really fantastic, and it's a really great building block for us, but we definitely identified some areas that we wanted to expand, or just some things that we wanted to have to make our program stronger. For me as a sexual health educator, I wanted to see more content dedicated to sex and sexuality and sexual health. So like, first of all, answering that question, what is sex? And that's something that is really complicated, like I said, and the answer is gonna change depending on people's like sexual identities and stuff. But I think it's really important to cover that as well, not just those risks and consequence factors like disease and pregnancy. And then we also want to focus on the pleasure principle. So for people with intellectual disabilities, we often spend so much time trying to protect them that we forget about the part where sex is supposed to feel good. And lots of other people know that, but it's important that when you're working with this population that you do stress that like one of the reasons that people have sex is because it feels good. Like, sure, we have sex because we want to have babies and reproduction and taking over the planet and that kind of thing. But one of the driving principles is going to be that it feels good. And so it's important to explain that as well. And then just in terms of program stability, we also want to incorporate assessment and evaluation processes. So that is the assessment that Amy was talking about in advance of starting the program, so that we can ensure that participants kind of have a similar understanding so that they can progress through the program at the same stages. But then also having a tool to evaluate the program after it's finished so that we can see where our successes were and maybe what areas are lacking or need some sort of change.
So persons with intellectual disabilities develop sexuality the same way as they do with typical peers. Persons with intellectual disabilities may struggle with social cues and social norms. So as individuals are developing and going through adolescence and whatnot, they may not understand the same way that their peers will. An important thing to consider is that we still need to talk about pregnancy, STIs, consent, boundaries, and pleasure. Even though that's something that's been really kind of off limits, we really need to move in that direction in terms of educating. That's the same way we would anybody else. Talking about sexual abuse and exploitation is particularly relevant. So as we had mentioned earlier on in this presentation, there is definitely a higher risk for individuals to be vulnerable to sexual abuse and exploitation. So it's important, I think, to have that education in order to help individuals make informed choices so that they're not put in situations where they are more vulnerable. One thing that I know we definitely learned during the delivery of the program is to make sure that everything's really clear, using visual demonstrations and actual hands-on exercises really helps to educate the individuals with intellectual disabilities so that they can actually absorb the information. And we also want to ask what they know to educate, expand, and demystify. So we want to make sure that we really have a good understanding of where they're at, and then provide that education to them as you move through that process. You want to also make sure that you're using simple and correct language, and then obviously repeating it. Repetition, I know when we were delivering the actual modules at the very beginning of each group, we would reiterate what we learned from the previous class. And as we moved through it, I really noticed that some of the individuals were really starting to grasp the concepts as we repeated it and repeated different exercises and used different visual cues.
All right, question 3. Individuals with intellectual disabilities have the right to make decisions regarding their sexual wellness and health. This is true. There is still a pervasive attitude within society, whether it be in our province here or across Canada or elsewhere, that individuals with intellectual disabilities do not possess the capacity to make choices in their own lives, especially around the way they express their sexuality and choosing their partners. This again kind of comes down to a protectionist or institutional attitude of support, that all those that we support are vulnerable and they need to be insulated or isolated from individuals that may cause them harm. But we also see this expressed within families as well. We have supported individuals that have been sterilized. Consent was given by their family members. They thought it was in their son or daughter's best interest to not be able to have an unwanted pregnancy. or not to have a child that they perceive would not be cared for well because of their intellectual disability. And this was obviously carried out with medical professionals in the field. This is kind of like the crux of this partnership and supporting individuals, is that even though we have seen a reduction in this type of behavior and attitude, but it still very much exists within our cities here.
So just some tips for healthcare professionals. So when somebody, you know, comes in for a medical appointment or questions or whatever, I think it's just really important to keep in mind that utilizing visuals for complex ideas or concepts are incredibly helpful in terms of helping somebody understand something. Sitting down and drawing a picture versus talking about it can sometimes get the point across in a much simpler and more especially with complex ideas. It just breaks it down into more simple terms. Make sure that you're using plain language. I know medical jargon can be pretty intense, and just making sure that you're really breaking it down so that it's pretty simple language is really important. I think it's also really important to realize that when people are coming in, get to know them a little bit and their personal life experiences. Building that relationship is vital in terms of creating that dialogue between them and yourself. And make sure to take extra time to speak with the individual. So I know I've attended medical appointments and such with individuals with disabilities, and unfortunately there have been times where the medical professional will turn to me as the supporter versus the individual. And I think it's really important to remember that the individual, you know, has a voice, and it's not about me, so it should be directed towards them. And just make sure you're compassionate and really listen actively. Sometimes things can take longer in terms of having those appointments with individuals with intellectual disability. So it's just important to really make sure that you've scheduled that time so that you can be compassionate and listen to everything that they need to say.
And what I have here are some tips for parents and support workers and educators in terms of young people and sexual development. So first of all, and this is really important, start early. I always explain this in terms of like when you go to school, they don't just start you on trigonometry, you start with addition and subtraction and you build your way up. And that's the same concept that we want to employ when we're talking about sexuality. So that doesn't mean saying to a little kid like that you need to explain to them what pornography is at age 3, but what that does mean is that you can teach concepts like consent from a young age, like that's your body and you are allowed to decide who touches it. You can also make sure that you put an emphasis on using correct terminology for anatomy. That's also really important. We don't want to be talking about hoo-haws and ding-dongs or whatever. It's really important that you say penis and vagina and vulva so that young people know the proper terminology, and so that if there is a situation where they are being abused by someone, that they have the language to communicate that to a parent or a guardian, whatever. Also, try not to panic. Kids will ask questions for shock value, but the best thing that you can do if something takes you off guard is just say like, great question, or like, where did you learn that? This is a really pertinent tip for parents, and that is don't force eye contact. I know that there's this long tradition of sitting kids down to have the talk once in their lifetime and only once, but that's not super effective. So it's easier to have difficult conversations in like the car, for example, and I recommend that one all the time, because if the kid's in the back seat, they don't need to be making eye contact with you, and you can focus on the road and they can kind of ask you questions. They're also a captive audience. They're not going anywhere. And that eye contact thing might also be more pertinent for people with varying disabilities as well. So remembering that just because someone's not making eye contact with you doesn't mean that they're not listening. Also, keeping answers accurate, honest, short, and simple. So my rule is that if a young person has the idea to ask a question, then they deserve to know the answer to that question. So that doesn't mean that you need to go into big, elaborate responses, but if you can answer the question as short and as quickly as possible, but with a truthful answer, that's going to be most effective. Also, I mentioned this one already, but normal changes. So we have a tendency to be like, oh my God, I never did that when I was a kid. But what you did when you were a kid is probably different than what your parents did when they were kids. And that's something that changes generation to generation. So the things that young people are dealing with now is their reality, and so we need to meet them where they are in those. You also don't have to have all the answers. I know that as educators or as professionals, when someone comes to us with a question, we feel like we need to answer that question right away, but it's perfectly fine to say, like, great question, I'll get back to you with an answer, or you know what, that's really interesting, but I'm not sure. And if you do that, just make sure that you do actually get back to the person with the answer. Also, using teachable moments is really good. So that means when you're watching Planet Earth or whatever, and a kid has a question that comes up, like, what are those lions doing? It might be a great moment to have a conversation about what those lions are doing. And also, don't wait for young people to come to you with questions. You can also ask questions to them about their experiences, what they've seen, and that's particularly good for stuff like pornography, like, hey, have you ever heard or have you ever seen this kind of thing online? Because chances are that they are, or that they have, and so it's a good opportunity to get into that with them a little bit more. And I think that brings us to the end. So we are going to move into questions here, but I did just want to note that following the questions slide in the PDFs, you'll have access to some of the resources that we used for information for this presentation. So if you're looking for additional supports and stuff like that, there's some good ones listed in the resources at the end.
Awesome. That was a great presentation, guys. Very interesting and very informative. Yeah, so if you're still with us, just use that questions tab and type in any questions you may have for our presenters. Will we access to the handouts? This is a question about the handouts real quick. So you have, you should have a button that says handouts, and below it you have the PDF, and from that you can just download it straight to your computer. So there's actually a lot of questions about people wanting to know if there's going to be anything more about how the modules are run or something more in depth. Do you have the curriculum? Can we buy it? So it seems like a lot of people are interested in replicating what you've done. Do you have a model for kind of expanding this so that people could, if they wanted, pick it up and kind of recreate it in different areas?
Yeah, so that's a really good question. So we're working on putting together a revised edition of the original program that we offered. So the best way to access probably what we're working on and to maybe open up a conversation with us is if we can disseminate our email addresses at some point, and then people can just get in contact with us directly. And I mean, we'd also love to just have more of a conversation and get some ideas about what everybody's thinking about, or and it's very much kind of a living document, like Natalia said, like as things change, you know, what we've experienced and what our reality is with our relationships is maybe something very different than others. So it'd be nice to get some perspectives on that as well.
Yeah, for sure. If you guys would like, you can share your email addresses in the chat. In the chat box, if you just type them in and make sure that the to button says entire audience, then everyone in the audience will be able to see your email addresses, and if they'd like, copy them down. Let's see. One person's asking if you could give some examples of the modules. Run the modules more in depth.
So the program consisted of 10 modules, so I can give a little bit of an overview in each one quickly. So module 1 was more or less just an introduction in terms of us introducing ourselves and breaking the ice, that sort of thing. So effective communication skills and identifying and responding to feelings. So we just kind of wanted to assess where everybody was at in terms of interaction and just kind of building up that relationship of trust. So module 2, I guess I should also mention that when we would drive out to Bigger, which is about an hour away from Saskatoon, and we would deliver the program in about an hour and a half. Within that hour and a half, we'd also take about a 15-20 minute break in there. And I almost would like to say that at times that was a little bit too long in terms of if there wasn't enough I guess interactive activities provided. So this was a program that was put together and we just wanted to deliver it and then reassess it in terms of what we would like to add. So that is a really key piece, is making sure that we add a lot more role modeling or role playing and visual interactive type activities. I think that would allow us to be able to deliver that program in an hour and a half with the 15-minute break more effectively. So module 2 is building self-confidence and personal safety. So that was really touching on, you know, assessing an individual's self-confidence so that they realize that it's okay for them to say no. I think in terms of supporting people with intellectual disabilities, they are often being supported by a number of people and are expected to adapt in so many different ways without question. So it's really important to empower them in terms of their own personal safety and building their self-confidence so that they have that right to say no. Module 3 was health and wellness, so I kind of touched on that very briefly. So we pretty much went through an entire hygiene pack, and we talked about hygiene, showering, brushing your teeth, putting on deodorant, and then we also provided them with hygiene packs that they could take home, which the Bigger community, the support, the teachers, the social worker at that particular school went out and approached the dental office for toothbrushes and toothpaste and that sort of thing. So it really kind of brought the community together to support that. Number 4 was decisions and making choices, exploring dreams and goals. So it was really, I guess, helping individuals in terms of understanding a decision-making process and seeing kind of where they're at in terms of their own goals and their own dreams, whether that be having a relationship or traveling the world. It was just really still building that self-confidence, and then also understanding that decision-making process so that in the event they're put in a position, they kind of have the steps and the skills to make those informed decisions. Number 5, understanding relationships, healthy and unhealthy relationships, and developing and maintaining friendships. So we do that in our day-to-day relationships, but for individuals with intellectual disabilities, sometimes that can be a little bit more challenging in terms of developing relationships and maintaining friendships, or even having those opportunities. I know Dallas had touched on that couple who were being intimate in the middle of a living room with other people around, and I think that is more common than we realize because there is no social outlet in terms of how to have some of those more intimate relationships. Module 6 was social relationship boundaries, exploring trust and exploitation. So some of these modules were pretty heavy in terms of the information we shared. So we would deliver the information and the individuals in the group would ask questions as we went. So in the event that we weren't able to finish the entire thing or really good dialogue came up, then we would come back to it the next week. Number 7, dating and romantic relationships, communicating in relationships. There was a number of people in the group that a lot of them wanted to be in a romantic relationship and just didn't quite understand how to make that next step in terms of how does it move from a friendship to dating, and then eventually from dating to having sex, that sort of thing. Module 8, being safe online, meeting people, online dating, pornography, and masturbation. There was definitely in our class a lot of I'd probably say 2 out of the 4 male individuals that participated had a very strong familiarity with pornography and masturbation, and had acknowledged the fact that that was their outlet because they didn't really have any other outlets. So it was also educating them on other ways to meet people, whether that be in the online world, and how to be safe when you're doing it. So reaching out to your supports and such. And then number 9, pregnancy, safer sex, STIs, and hygiene. And then we did a review and wrap up on number 10 the last week, where we had just an opportunity for people to ask any questions at the beginning of each class, or as things came up in each module. We had a flip chart where if it wasn't part of that particular module, we would put it in the parking lot. So at the very last class, or as we move through, we answered all those extra questions. I know I'm describing at a very high level, and I can definitely provide more information. I believe Dallas posted our email addresses. Yeah.
And like the other thing I want to point out here is that pregnancy, safer sex, STIs, and feminine hygiene was all just one module. And for me, I teach that to a typical classroom and almost like 3 sometimes. So some of the stuff that got a lot of priority was that relationship information, which is important, but in the end, I kind of felt like exploring dreams and goals wasn't quite as pertinent information as like understanding basic anatomy and how people get pregnant and that kind of thing too. So those are some of the changes that I think that we're going to be looking to make when we are evaluating the program.
Awesome, thank you. So we can go through a few more questions here. So this participant said that she's at a large institution in Texas where they have guardians, and she wants to know what is the best way to approach them about this topic and about engaging their loved ones in this type of training.
Yeah, that's a really good question too. So we have supported individuals that have legal guardians. That may be a family member or somebody else in the community that's been appointed through our court system. That individual's capacity has been tested or assessed, and it's been determined that they're not able to make choices for themselves. So essentially, it strips them really of their human rights. That being said, just because you are somebody's legal guardian doesn't necessarily mean you can't empower that individual and engage in a co-decision making or a supported decision making process. So that's typically been how we have approached the human rights of the individual and the supports around sexual education and wellness, is that, and that's kind of a component of what we've worked on with this program as well, is providing that direct support to caregivers, to family members, to support workers, agencies, other community-based organizations. We've had to have those you have to have frank, honest conversations with those guardians or with those caregivers, and really root the supports that you're providing through sexual wellness and education along those lines of human rights, and that it is best practice to make sure that the individuals that we support, regardless of what their capacity is, and who is responsible for their care and support, that they are entitled to that information, that it is beneficial information to them, and whatever decisions they're going to make in their personal lives and the choices surrounding those individuals that they choose as their partners in any form of intimacy is going to be well informed. And you can't, regardless of what a court document says, you can't control people making those choices. I think humanity as a whole has always found out a way. When we're restricted in any capacity, we always manage to problem solve to get what we want. And that's very true to those that we support with intellectual disabilities. They typically come from environments or backgrounds where many of their choices and much of their independence has been decided for them, again, by well-intentioned family members or other community members. Mm-hmm. But the reality is they are not living inclusively in their communities with that attitude of support. And again, this kind of comes back down to very much a protectionist perspective. So the best advice would be engaging in those meaningful conversations with those guardians and with those family members or those individuals, and provide them the exact same information that you would be providing participants in your programming, but really rooting it within that this is very much, and it could be done there as well, a human right, and that they deserve to know, because the more knowledge they have, just like anybody else, the better decisions and choices that they're going to make when it comes to their own personal lives and relationships.
Sure. Great, thank you. So I'm going to do one more question. It's getting a little late. So this participant asked if there's a structured program like this that's already in place in any other province that you're aware of, and if so, how are they funded?
I can't say that I was aware of any programs like this, and we did do a bit of an environmental scan previously, but there wasn't anything that stood out. I know that there's a couple of models for programs about what should I call it, relationships for people with intellectual disabilities. One of them is called the Circles program, and what's the other one?
Relationship boundaries.
Relationship boundaries, but the thing is that neither of those really focus on the sexual health, sexuality aspect, and obviously coming from Saskatoon Sexual Health, that piece was really important for us. So I think that this program is kind of novel in its conception from Core in Regina and the Tell It Like It Is program, and I'm really excited to see where we can take it. I think that we've been really fortunate to have so many different organizations involved, and that's created a really well-rounded program. And like I had mentioned, we were wanting to do a stakeholders meeting. And so we actually have that coming up at the end of the month, and there's people from the school boards that are going to be involved in that, from different agencies in the community, and different healthcare professionals as well. So it's my hope that we can have everyone really sign on this project and then develop something that works across the province in a kind of unified manner.
Yeah, for sure. You guys can make the standard. Get some data on this, and I'm sure people, I mean, our participants are already very interested in it, and as far as I'm concerned, I've never heard of any programs like this, so it seems like you guys are onto something. So with that, I don't think, it's getting a little late, I don't think we're going to take any more questions, and we've answered most of them. But I just wanted to thank you guys so much for this awesome presentation. Definitely a very important subject, and I think that our participants would agree that it was very informative. But with that, I just want to say once again, thank you and have a good night.
Thank you very much.
Yeah, thanks. It was a really great opportunity.
Yeah, no problem. Oh, I also want, if you're still on in the chat box, you can grab their email addresses. And if for whatever reason you missed them, just use the flyer to get to me and I'll forward them to you. Great. Have a good night, everyone.